Now we'll invite Dr. Praful Sharma, and he'll be talking imaging calcified lesion.
Yes,
How
sir.
do I plan my procedure? Dr. Praful Sharma?
Yes, sir. So it's actually very difficult being the last speaker of the day, but I'll try and finish off quickly. First of all, I would express my heartfelt gratitude to the organizer, especially Dr. Khanna, for inviting me to give this talk in this August conference. And I'm very honored to share the session with the stalwarts of intravascular imaging in the country. So I would be talking about how do I plan a case of in a calcified coronary lesion. As you all know, there are four major enemies of the interventional cardiologist. The biggest one is calcium. The other three are, I will say, lesser enemies. They are tortuosity, high thrombus content, and diffuse atherosclerotic disease. But calcium historically has been the biggest enemy of the interventional cardiologist. I think we have all underestimated calcium at some point of life in our early interventional careers, and then have struggled with the delivery of balloons, stents, and hardware. We have dissected the arteries, underestimating the calcium, dissected the arteries. Patients have gone into angina on table, hemodynamic compromise. Then we resort to quickly stenting the artery and find a suboptimal stent expansion, which would ultimately not open with a high pressure balloon. So I think all of us have gone through these kind of scenarios, and I would not go into the this thing. Like we have all seen these kind of cases which will not respond to any of the conventional treatments. Then this is classically called as aorta regret. It happens as a result of underestimation of the number one enemy of the interventional cardiology, that is the calcium. Now, the lesions with high calcium content, they are generally found in patients who have a higher burden of comorbidities, and they are associated with more extensive coronary atheroma. Now, treatment of these lesions using percutaneous techniques is complex because, as you all know, they are challenging to cross and difficult to dilate. There's an increased risk of incomplete lesion preparation, and which ultimately will end up with a suboptimal stent deployment. Now, suboptimal stent deployments or under expansion has a very high rate of acute and chronic stent failure, as we all know. In addition, there is a high incidence of intra-procedural complications such as no reflow, coronary dissection, and perforations. So, to emphasize the importance of imaging, the use of imaging for routine procedural planning in treatment of these lesions, I have decided to show you two very simple garden variety of cases. Now, these cases are not exotic. These are absolutely type A and type B kind of lesions. With these cases, the first thing which I would like to bring out is the limitation of routine angiography to detect and characterize calcium content. And the number 2 point is, how can this intravascular imaging help me to select the correct treatment modality? Now, there are a large number of treatment modalities available to the interventional cardiologist, starting from various kind of neo balloons, the various atherectomy devices, even laser, intravascular lithotripsy, and a number of other techniques. So how can imaging help me to upfront select the correct treatment modality, which will depend on the amount, the character, the distribution, and the severity of the calcification, and how will this algorithm, how can we use this to improve short-term and long-term results to make the procedure safe and, most importantly, stress-free. Now, the first case, I will go through it quickly. A 64-year-old lady with classical angina for the last 4 weeks, hemodynamically stable, no changes in the ECG, the echo function was normal, no reasonable motional abnormality. We took her for a stress echo, and which was positive, and this was the coronary angiogram. Now, if you can see in these images, you hardly see any calcium on the conventional angiogram. Even the lesion in the LAD looks borderline. So we thought we'll just confirm it and do a intravascular imaging. Now, if you see in various views, the lesion in the LAD looks borderline, and it does not show us any significant amount of calcium. So if in the pre-intravascular imaging era, I would have straight away gone with a balloon and tried to dilate and tried to put a stent. But since we had OCT on table, I would skip the run and show you the cut sections. You were surprised to find that the lesion was definitely significant, and at number of places, you see it had the lady had concentric calcium. You can see, in the images C and D, you can actually appreciate concentric calcium and more than 0.5 millimeters thick. In addition, there was he had lipid-rich plaques, and the up to the proximal LAD, she had significant disease. So we decided to do a rotablation with the 1.25 mm burr. She started developing some pain on table, so we immediately we could not step up the rota. We tried to use plaque modification using a scoring balloon. Now, if you can see the scoring balloons, even the scoring balloons are not opening satisfactorily. That means even after the rota of 1.25, we actually, in hindsight, we should have switched over to 1.5 rota burr. But then, since the patient started developing pain, we had to shift quickly to a scoring balloon, and then try and finish the case quickly. So we deployed a stent distally, and patient, the BP and angina was relieved with the inotropsin pain relief. OCT was done again, and we could see a lot of, again, it sprung up a lot of surprises. So the proximal lesion in the LAD had dissected quite nicely. The distal struts were well opposed. So depending on all these, features, we quickly put one more stent in the proximal LAD and completed the case with a good angiographic result. Now, another case, again, was a 56-year-old male, diabetic and hypertensive, crescendo angina for a month. ECG was sinus rhythm, echo normal function, and he had a reversible perfusion defect in the LAD territory. Now, if you see again, the LAD again does not look significantly calcified. So the OCT again sprung up some surprises, but not so much as the previous case. Now, this OCT showed a non-concentric calcium. And if you see the B and C images a little carefully, it is a deep calcium. So you can see a little fibrotic plaque, the thick, intimal layer between the calcium, and the calcium seems to be subabluminal, not superficial. So we decided to go in with not with the atherectomy balloon. We decided to go in with a dilatation first with the NC balloon, and then we dilated the lesion with the 3x15 open NC at very high pressures. Now the lesion gave way, and we repeated the OCT and finished the procedure with a good angiographic result. This was the stent expansion, and this was the pre and post PCI MLA. Now, why calcium is so important? I would stress this again, that calcium is present in 90% by the age of 70, and it is underdiagnosed by conventional angiogram. A landmark study by Dr. Mintz et al. Showed that angio is detected by, the calcium detected by angiography in 38% of patients, and in the same patients, it can be detected up to 73% by IVUS, by using IVUS. The presence of calcium increases underexpansion and further adverse effects. Now you see how badly conventional angiography fails in describing the characteristics of calcium, which are a very important factor on which the treatment depends. Basically, with all these factors, we can actually decide what treatment strategy to use. So when you are diagnosing a LSCC, it is important to differentiate between deep nodular superficial calcium, because that is important. If it is a deep calcium, as it was the second case, we could have used traditional techniques like balloons and scoring and cutting balloons. If it is a nodular or superficial calcium, you have to use debulking devices and plaque modification devices. Like, for example, just to give a little bit of overview how superficial calcium looks like, deep calcium and nodular calcium. Now, OCT allows unique in vivo characterization of coronary artery calcification. Recognition of the features of calcified plaque that can predict stent underexpansion is important for selecting appropriate lesion preparation strategies. Now, there are various OCT-based calcium scoring systems, which are initially it was described by Fujino et al., which is this, and which is also known as the rule of 5. Now, if a pre-stent OCT demonstrates maximum calcium angle of more than 180 degrees, that means more than 50% of the vessel arc, continuous length of more than 5 millimeters, and calcium thickness more than 0.5 millimeters, the lesion, it has a high risk for stent underexpansion with PCI. Consequently, these lesions should be treated with a upfront lesion preparation strategy to facilitate plaque modification and calcium fracture prior to stent implantation. This can be achieved with lesion preparation either with IVL, orbital atherectomy, or rotational atherectomy, or whatever the various debulking techniques which you have. Now, historically, atherectomy devices were reserved for uncrossable or undilatable lesions. In recent years, there has been a paradigm shift to an upfront lesion preparation approach to modify calcified plaques to maximize stent expansion. This comes with an important distinction. With lesion preparation, the goal is not simply to facilitate stent delivery, but rather to optimize stent expansion. Now you see, if in the first two images, if there is no calcific burden, you can do a direct stenting. If there is a low calcific burden, we can use conventional strategies like compliant balloons, NCS scoring balloons. For high calcific burdens, especially superficial or in for example, in NIH or nodules, you should be using upfront atherectomy devices to make the life a little easier. Now, there are various algorithms available in the medical literature. This is the easiest algorithm which I could find. So I will just take another minute to explain this algorithm. The goal of the lesion preparation with severely calcified lesions is calcium fracture to facilitate stent expansion in the end. So there should be an algorithmic approach to treating calcified lesions. Our approach is grounded in OCT and its ability to efficiently characterize the degree of calcification and systematically inform optical device selection as well as assess the treatment efficacy. Now, first of all, we see whether the OCT catheter or a balloon can cross. If the OCT catheter or the balloon doesn't cross, the patient should be taken directly for a rotablation. If on a repeat OCT there is a fracture of calcium, then the stent can be implanted. If the calcium is not satisfactorily fractured, the patient can either be dilated using an NC balloon or a IVL balloon, depending on the amount of calcium remaining. If the OCT catheter can cross easily, then you have to assess whether the calcium is deep, superficial, or nodular. If the patient has a nodular calcium, again, and significant nodular calcium, again rotablation, and then going on to the same procedure. If it is fractured, stent. When the calcium is deep or superficial, when the calcium is superficial, and it fulfills the criteria, the rule of 5. That means it is more than 50%, it is more than 0.5 millimeters, and more than 5 millimeters in length. Then you have to decide whether you should go in for a conventional techniques. If it doesn't fulfill this criteria, all conventional techniques can be employed. If it fulfills this criteria, and if it is balloon crossable, then the first choice in today's scenario will be IVL. If it is balloon uncrossable, again, rotablation followed by stenting has to be done. Following stent implantation, OCT should be performed to ensure adequate endpoints have been reached, with further stent optimization employed as needed. Liberal use of balloon pre and post dilatation are employed as needed before and after.
Sharma, kindly conclude your slides.
Yes, I'm finished, sir. So to conclude, identification and estimation of calcium is important. Calcium, as we all know, if not ablated completely, will lead to underexpansion, which can actually complicate the procedure and lead to poor long-term results. Underexpansion, malposition may lead to acute and chronic stent failures. And OCT, as we all know by now, is an excellent modality to plan and optimize coronary intervention, especially in calcific lesions. Thank you. I've finished.
Thank you, Dr. Praful Sharma, for the excellent talk.